So the First Nations Mental Wellness Continuum Framework, as some of you may know, is a framework that I mentioned was launched in 2015 by Thunderbird, ourselves, the Assembly of First Nations, and First Nations Inuit Health Branch. And it is a framework that is meant to provide support and guidance and some resources, or help identify resources that our communities can use to address and build mental wellness in the communities. It's meant to ensure that there is a quality mental wellness workforce across the community, across Canada. So using this almost like a bit of a standard approach that can be adapted and aligned to meet the needs in communities based on their priorities, their language, their needs. And at the center, or at the foundation of this, is using culture as the foundation to work on mental wellness. And without going into all of the details of it, it really is intended to give some guidance around building systems change and around how to create, design, and develop and implement mental wellness programs in our communities. And we've used this framework as a way to think about the mental wellness workforce that we're visioning to create this association on. And so what we know is that the skills and the knowledge and the behaviors that guide our workforce has been critical to ensuring that there's a quality system of care that we're providing to our people. We know in our work in the past, we often were told by government, this is the program and this is how this is the program you have to implement and this is how you're going to do it. But things really were not benefiting our people. And so over the last 10 to 15 years, there has been a much greater emphasis on the use of our culture, our language, our knowledge, and our evidence as ways of building building a system of care that meets our needs. And so we had the question about what type of knowledge and what is the knowledge and the skills and the behaviors that we need, that a workforce needs, to ensure that they are providing quality care and having quality outcomes in mental wellness for the people that they are working with. And so that was the question that has guided the work that we've been doing in exploring and talking to workforces and others about the creation of an association. And so when we asked that question, these are some of the things that we heard. We heard it's important to build competencies, and those competencies are built off of a few things. One is on a knowledge base, a credible knowledge base around mental wellness that is based from our cultural understandings. It's also about having a set of skills to be able to deliver programs and services that meet our needs. It's also about the behaviors. So as a workforce, what are our behaviors? How do we not only model mental wellness, but how do our behaviors in terms of developing partnerships, working collaboratively, working side by side with those community members, the families, those kinds of behaviors. We have to have a set of behaviors to do this work and do it well. There also has to be opportunities for learning, so competencies in how we learn, what we learn, and ways of learning. So we know that this isn't the only way to learn, is sitting and listening to somebody talk, right? Sitting with our elders, listening to stories, being on the land, those are other ways of learning. We also heard it's important to think about competencies in terms of experiences. What kind of experiences do our workforce bring that helps to build competencies? And then the need for perhaps more advanced training. That might be through educational institutions, but it may also be on the land, those advanced types of training that we would get from our elders and our knowledge keepers about understanding cultural practices. And when I think about our workforce, our cultural practitioners in the IRS programs or in our mental wellness teams and in our communities, that takes years and years and years of sitting and being mentored by elders. That's that kind of advanced training that we are thinking about. And then our abilities, what are the abilities we need to have to show competencies? And finally, growth. How do we continue to grow as a workforce for our competencies to continue to evolve and support the people we're working with? And so at the heart of that, we heard it's important to think about culture and to think about the holistic approaches to mental wellness and holistic approaches to care, and how do we have competencies in that realm of thinking, and that it must be inclusive of the Indigenous social determinants of health. So that includes, as I said earlier, language, land, identity, culture, and it must come from a First Nations context. It has to come from our ways of knowing and doing and being. So we see that this association would have a few core functions. The one that we've spent a lot of time working on, both at Thunderbird and First Peoples, has been thinking about core competencies. What kind of core competencies would be necessary for the creation of a workforce? We already have a workforce, I should say. So how could these core competencies define who is our workforce and what they do, and how they do that work? And so we've had lots of conversations, and Carol will talk a little bit more about that later. But we also see that it would be an opportunity for the creation of a certification framework. So what would help you to be certified, to show that you are a certified First Nations mental wellness worker or workforce. So if any of you have heard of the First Nations First Nations Health Managers Association, they have a certification program thinking very much along the same way, that you would take certain training, and at the end of so much training you would become certified, same kind of idea. And we have others that are happening now in the country. The Health Professional Association is doing some of the same things, so thinking in that same vein. It would also allow us to think about continuing competencies, like we said, that growth piece, and having various educational series, so that when we go to communities and we're looking to hire mental wellness workforce, there could be a bit of a standard understanding of what should somebody doing mental wellness, what should they know, what should they be able to do, what kind of skills should they have, and we'd be able to build on those and give them that advanced training. There would also be a code of ethics. So when you go to most associations, there's a professional code of ethics, but our code of ethics needs to be inclusive of our cultural understandings and our cultural values, and that would need to be included. We wouldn't find that, like in the Psychological Association's code of ethics, they don't talk about those things. And in fact, if you think about in our communities, some of those code of ethics, if you belong to social workers or psychologists, they say you can't have a relationship with your client. You can't accept gifts from your client. But how many of you here have gotten a gift from one of your clients because they're so thankful for something you have done? And if you don't accept that gift, what does it do to our relationship? Because there's meaning behind getting a gift, right? So it doesn't mean we're going to say, hey, can you do this for me? But we would have to think about those cultural values and principles and how they need to be built into a code of ethics. And the same thing around dual relationships. It is very common for us working in our communities to have dual relationships. So having a code of ethics that can help our people navigate those types of dual relationships and how to do our work well, but still maintain good relationships within a community, because those are just as equally important. Another thing we are looking for with core functions is creating standards of practice with culture as that foundation. So those standards of practice is how do you go about supporting people dealing with complex trauma, let's say, or dealing with concurrent issues of substance use and mental health. So having standards of practice that can help guide the way our work is done, and also provide a bit of information about the types of tools and resources to support people in those standards of practice. And those can all be then helpful to a workforce in delivering programs and services that meet the needs of the community. Because we know sometimes, particularly during COVID, many of us felt quite isolated. I'm just doing what I think I gotta do. I'm not sure if this is the right thing to do, but it feels right, but I'm not sure. That's why we come to these types of gatherings, right? Is like, are we doing the right things? Is this what everybody else is doing? So we get some support. So this association would be an opportunity for those ways of checks and balances. Is this the way to support somebody with these different types of needs? And I would say that the standards of practice are not just at an individual level, as well as the supports and resources, but how do we do it for families, and how do we do it at a community level? Again, thinking about our framework, that we must invest at community and family level to be able to see those more significant changes at an individual level. If we have less funds, we can't just be investing in a person, we need to invest in our collective, which goes back to our values of collective healing and well-being. And we see this association as an opportunity to liaison with other professional associations, because we know that some of us are going to be trained as social workers, psychologists, social service workers, psychotherapists, those different ones, associations we might belong to. And many of them have said, well, we don't know how to guide some of this, or we get asked lots of questions, but we're not sure how to do some of this work. So that liaison, so that we can be the voice, again, that comment we had earlier around self-determination, we're determining what that looks like, and then advising other associations. And finally, a governance component to it. Who should govern this association? Our boards, both Thunderbird and First Peoples, have had that conversation already. Who would govern this? And both of our boards have said it would be critical that the workforce are the people to govern it. So they are determining and making the decisions around regulations and oversight and all of those kinds of things. And that Thunderbird and First Peoples would support that governance component. Some of the foundational activities that we see this association being able to do is using the overarching descriptions of the framework, those key concepts of the framework, to help us think about the creation of the association. We are looking to develop descriptions around concepts that impact mental wellness, and those might change. So the methamphetamine use and opioid use, as things change. Our homelessness is a big one now. Emergency management, health emergency management, being able to have those concepts and support the workforce to think about how they attend to those needs as they arise in the community. And then to be able to obtain feedback from the workforce about the what we're gathering and what we are proposing, to make sure it matches the understanding of the workforce. And then we look to lead the confirmation of the core competencies, so understanding what they are around knowledge, skills, and behavior, and giving an overall description of those. The National Workforce Association, we began by identifying some core competencies across themes, and that was based on work that had previously been done through Thunderbird and First Peoples. And so there are 6 themes. We have culture and trauma, harm reduction, substance use and mental health, service components, and populations, and each of those had a number of competencies, as you can see. And we have expanded some of those further. But the engagement criteria, we also looked at thinking about practice-based evidence. So often in Western knowledge, it's been called evidence-based practices, but we know that what works in our communities is practice-based evidence. What we are doing works, and that makes it evidence. So really wanting to center and ground that as part of these understandings around competencies. Making sure that we're attending to critical areas of need, or those that are being misunderstood in terms of how to support in the areas, particularly culture might be seen as one that gets misunderstood, or harm reduction from our own lens. We want to make sure that it doesn't duplicate any existing addictions or health management core competencies. So we are going to have conversations with the Health Managers Association, who have some core competencies around mental wellness, so it's not a duplication. We want to be able to make it either enhance it or complement it. And the same thing with addictions. There are a number of core competencies within the addictions workforce, so not wanting to duplicate what already exists. And that it needs to fit our own lens, and it needs to have an ability to facilitate growth as we build on that and create greater understanding about core competencies in this workforce. And as we've said a couple of times, ensure that it comes from a foundation of culture. Slides, looks like it's there twice. And so the work that we've been doing, you see those core competencies along the top around culture, trauma, harm reduction, substance use, mental health, service components, and population. We have been continuing to build those out. So in the area of culture, this might be really hard to see, so I'll read it in case it's difficult. What is unique to your nation of people that is critical for the workforce to know, have skills to support or to act on, and to identify where the workforce would not have a role. So thinking about that, so it could be looking at things like culture as the foundation, Indigenous knowledge, cultural-based practitioners, land-based healing, traditional healing and culture interventions, cultural competency, cultural safety, strengths-based approach, and then with trauma category, the question there is asking what is unique to your community, population, or Indigenous people that the workforce should know about, understand the skills necessary to support and act on. So thinking about things like intergenerational trauma, trauma-informed care, or work that I like to call healing-centered care, so maybe changing that to healing-centered care, moving that forward a little bit more. Complex trauma, colonization and decolonizing. You see that this all flows into three main areas of trauma and service, culture, population, and substance use, and they all link out. And then we have harm reduction. In the competencies, identify what this looks like in your work experience, community, what knowledge, skills, and behaviors would have been helpful for you to have in a coordinated and consistent response. So here we're talking about contaminated drug poisoning, overdose, safer supply, harm reduction, human trafficking, and drug use, naloxone, and aftercare. So these would be areas we would be looking for competencies. In the area of substance use and mental health, even though your community treatment center service provider may not have provided the following service, think about the unique needs of people who use drugs and alcohol or appear to have a mental health condition. What knowledge, skills, and actions, behaviors would have been helpful to Indigenous people along the continuum of care. So thinking about addictions medicine, outreach, wraparound service, withdrawal management, early psychosis, drug-induced psychosis, trauma-induced psychosis. Service components. The following are unique to Indigenous people, experience, and impact on mental wellness. What unique knowledge, skills, behaviors are essential for acting in your role to prevent, respond to someone's needs, plan to address, and to coordinate allies. So the Indigenous social determinants of health, anti-oppression, anti-Indigenous racism, stigma, peer support, partnerships. And last, in the area of population, what are the needs of specific populations to their identity? What are those knowledge, skills, and actions that the workforce need to be able to support that population? And these, we list out a variety of populations: children, youth, those with chronic health conditions, MMIWG, qualified by experience, LGBTQ2S+, persons with disabilities, aging out of care, PTSD, all of these different populations. So we see this as a way to help us think through the core competencies using this graph and using those boxes as ways of thinking about areas to attend to different types of core competencies. And I'm going to pass it to Carol. Sorry. Shocking. She's a shockingly good speaker, eh? That's what happened to me. She shocked me. Yeah, the rest of the slides give more definition, and you know, the previous slide that Brenda was showing us, it's a lot. And so what that tells us is that since we have been talking more about a continuum of care for substance use and focusing more on what is mental wellness and understanding that within the mental wellness continuum framework, a lot of conversation has pushed these items to our attention, so that First Nations communities have said, here's where things are appearing in our community, we're not quite sure, or I need to understand more about it, or what is the knowledge, skills, and actions that I need to take as a frontline worker
And what's the knowledge, skills, and action that the manager or supervisor needs to have? Because maybe the manager is not in direct client care, but in order to make sure that the right policy facilitates that frontline worker's actions, then the manager has to understand, what do I expect my staff to do when we have the appearance of psychosis? How do we understand that? Because in our communities, there's not a lot of understanding, right? We have not had access to mental health care in our communities, and so we don't understand that language. In fact, when we were developing the mental wellness continuum framework, First Nations said, I don't want the title to have mental in it, mental wellness. We were referring to it as mental health, and they said, no. If we change it to mental wellness, I can live with the word mental in the title. But there was a pushback on that, and that's because we don't have a long relationship. We haven't had the service in our community, and we've been taught that there's an expert that does that. It's not us. And so it's at arm's length. So now that we're understanding, we do have capacity, we do have knowledge to draw on. And yes, we might need some expertise once in a while, but Brenda always says this, we are experts in our own trauma. And we have an understanding about what we can do, but we need to figure what is. And so the 10 years since the mental wellness continuum framework has been in our community, the 15 years since we launched the Honoring Our Strengths Renewal framework on substance use, both of those frameworks have raised conversation in our community, and this is where we are now. There's a better understanding, but we need to formalize it and create greater capacity. So the rest of the slides just say a little bit more about what these concepts are. And you know, when I talk about culture, I'm very grateful to be living in a time when we can talk about culture, when I can call out epistemic racism. Because when my mother was going to school to be a nurse, they didn't talk about that then. And when my father wanted to access traditional medicine, nobody talked about it. He wasn't even allowed to talk about it in his mind, wasn't even allowed to talk about that in the house. And so he went off quietly to see someone and get his traditional medicine for whatever he used it for. I didn't even know that. So, but we're in a time where we're having these conversations, so we need to raise the perspective that culture should inform the very foundation of our programs and services. Right now, it still lives on the periphery. We're not quite sure, how do we put culture into human resource policies? How do we put culture into programs and services so that it's the foundation and not just if we have time, if you believe it, if your workforce is saying, I'm allergic to that smudge, don't like the smudge in here. You know, in different provinces, there's legislation actually that protects smudging and smoking the pipe indoors. But in our First Nations communities, that's not always the case. And so this is helping to move that conversation along so that we develop a foundation of understanding that our workforce should have. I always like to use the example when you are interviewing for new staff, and say for example, you use cognitive behavioral therapy or motivational interviewing or the matrix model in your services. And if your prospective staff said, well, no, I don't believe in that stuff. And you're gonna say, okay, you've got the job. Come and work for us. You would never say that. But if they say, I don't believe in culture, you know, more than often we say, okay, you don't have to do that then. And so we're moving past that time now where we should not be apologizing for using our own knowledge and celebrating our own values and worldview to facilitate wellness in our communities. And so we're learning how to put that in policy, how to write human resource policy for supervision, performance appraisal, how to put it in our program design, at least that way of thinking. And not forcing, but facilitating wellness through that. So that's what all of these competencies are about, and I know I'm out of time. So even the presence of trauma, you know, we're moving from the belief that the social worker is gonna come in, the psychologist is gonna come in, and they're gonna do it all for us because we don't have the skills. And underlying a lot of this are the colonial harms, where, you know, we haven't had and we are not comfortable around conversations related to sexual abuse in our community. And it's, you know, we've got that tight lid on that conversation. Don't even say the word because it might trigger somebody. It's present in our communities, we know it. We know it. And what we need to do is take one step forward and say, I'm really sorry that's your experience. If you need someone to listen, I'll listen. That's it. Don't have to have all the answers. Don't have to have the right words, just know how to listen. And that's a huge help. And we have lots of culture-based ways that help us to create a safe space so that we can listen to those stories and validate people. So putting that in this context, the big ugly word is psychosis. That sounds scary to us. But with the presence of the drugs that are in our community, that psychosis is much more present. It's happening all the time. It happens because of the drug, like methamphetamine, that causes hallucinations, but it creates an imbalance that over time is going to have much more effect on our physical body in different ways. And depending on the way we are using, by injection with a needle, whether we're snorting it, inhaling it, all of those ways of using drugs will have an impact on psychosis and our ability to function. We need to understand that. We need to know at least some basic knowledge about what we can do about that. How do we manage that situation? Because many communities will describe people who are using drugs as zombies or the Walking Dead. You know, those TV shows? And it's almost like we've thrown our hands in the air and said, you know, that's just the way they are. And we can't accept it. But there are communities who are doing something about that, and they are making a difference. And they've come to a place of understanding that medication has a role to play. In some places that have grown accustomed to valuing culture, then they use culture to reject Western-based methods. And we can't do either or. In our reality, with the presence of drugs and the effects they're having, we have to use everything possible. Our future is under threat. And we have to change our thinking to learn about these things so we know how to use them effectively rather than be afraid of them. So that's what all of these are about. And you know, if we have a conservative government in Ontario, and you know, a minister says, you know, come to a conversation on substance use. And the first thing he says is, Carol, we're not talking about harm reduction. We're not doing harm reduction. Well, I never brought it up. You did. Okay. They're interested in supporting treatment, so it's a window that we need to jump through and get everything we can to help us with addressing substance use. So in the Honoring Our Strengths Renewal Framework, at the time it was the Harper government, and we were not allowed to use harm reduction. So in that document, it refers to harm reduction as secondary risk reduction. So changing the words to fit the environment of funding. And how do we address this at the community level? Because our communities don't have the funding and capacity. And so what ends up happening is we point to treatment centers because that's the only way we understand treatment. Well, treatment center, you should be addressing this. how come you're not fixing this issue? Or police officers, how come you're not fixing this issue? Or chief and council, you're not making the right decision, you just gotta kick all those drug dealers out of the community and everything's gonna be better. You know, we get into that place of desperation and we make these knee-jerk kinds of decisions that don't have long-term effect. And so we need to be thinking about how do we build up resources in our community and who are all of the partners that we can pull into the conversation to help us. So thinking about that, we don't have to know everything, but we need to know something about these issues and all of the ways that psychosis appears so that we can find those partners and help them to see that they have a role to play. And it's not us sending everybody to the city, it's saying, nope, has to be at home. And that peer support is absolutely necessary. I mean, we think about, you know, there's been a lot of criticism of the AA model, that that's not evidence-based, it's not effective. It was effective for us because it actually represented our values of supporting people. And so that's why AA was effective, because you could reach out to somebody 24/7. There was a relationship there. What's happening for people who use opioids and methamphetamine, they don't have relationships. So what do they have to hang on to then? And people who have lived experience, this is a new buzzword, they have a perspective that we don't have. And that's evidence of that lived experience is so valuable. But we hardly ever invite them to the table to help us develop the program or the policy. So peer support is necessary. And then we're always used to developing programs and services for adults. But where is the programming for LGBTQ2+ populations? How are they driving and informing what's needed in our communities? Because they too have left our communities because they don't get support in the community. And they've been working on harm reduction far, far longer than the rest of us. So it's bringing these conversations forward, and how do we educate our workforce and then certify that knowledge through a certification process. So we're continuing to engage audiences, because this is not just about mental health, it's not just about addictions. As I said, health managers, Brenda mentioned them, housing. There's a professional, First Nations Professional Housing Association. Housing has a role to play. Income support, Ontario workers in our community, they're faced with this all the time. And they often say, I don't have training in addictions, what am I supposed to do? Well, they can be involved. Even police force in our communities. They're at the front line dealing with mental health and addictions. How can these certification requirements or these competencies support them in their work? So it affects the whole community. And what we're trying to say is mental wellness is the foundation for the wellness of the community. And so across the determinants of health, can these competencies help build up our capacity across the community and different workforces to support a solution? And again, we've been talking about who should govern this. But you know, the training, the ongoing training and the supports that are necessary, those are all things that we are tasked with developing a business plan so that we could get some funding to establish this association and start moving this forward. So I'm going to leave it at that. There's, in the presentation, I'm not sure how they're sharing them, but the contact information for First People's Wellness Circle and also for Thunderbird. So if you have any questions or comments, I think we have 5 minutes. 5 minutes. Go ahead.